Ladies and gentlemen, I'd like to welcome you to this session of the combined online meeting of the British and Indian Hand Societies. I'm delighted to present an instructional course on osteoarthritis at the base of the thumb. We have a fantastic array of talent for you today. The mobility of the first carpometacarpal joint is critical to hand function. Rotation allows thumb opposition, with my thumbnail rotating through 180 degrees in these pictures. This mobility is due to a double saddle configuration of the joint, although the saddle sits on a rather scoliotic horse. The joint pivots around the palmar beak ligament, and this involves significant shear forces on the joint. This shear force results in frequent arthritic changes. The X-ray shows the typical features of subluxation, osteophytes, and joint space narrowing. A classical study from the 1950s, in which whole body X-ray surveys were performed in a sample of over 300 middle-aged people, found evidence of radiographic changes of thumb arthritis in 1/3 of women and 1 in 5 men. I could find no published studies in the Indian population, but believe the incidence of arthritis is likely to be similar. An elegant cadaveric study by Richard Eaton has shown that X-rays underestimate the true evidence of arthritic changes. Osteophytes are seen before cartilage loss, and associated scaphotrapezial changes are quite common. The changes are usually progressive, with subluxation followed by osteophytes and then joint space narrowing. This progression has been classified. Some reserve grade 4 for pantrapezial osteoarthritis with changes in both the carpometacarpal and the scaphotrapezial joints. Tim Davis has investigated the relationship between X-ray changes and symptoms. He found evidence of arthritis in 1/3 of a sample of middle-aged women attending with distal radius fractures. Only 6% of those with no visible arthritis reported thumb-based pain, whilst 1 in 3 with arthritic changes had symptoms, 6 times as high. The incidence of symptoms increased markedly with the severity of the arthritic changes. In summary, X-ray changes are seen in 1 in 3 middle-aged women and 1 in 5 men. X-ray may underestimate the severity of disease. Only around 1/3 of patients with radiographic changes are symptomatic. Symptoms are more common in those with severe X-ray changes, and scaphotrapezial arthritis is seen in around 1/3 of cases. The arthritis presents with pain and weakness and may progress to an adduction contracture with hyperextension of the metacarpophalangeal joint. In the early stages, there is swelling, tenderness, and instability of the joint with a positive CMC joint grind test. Pain on radial deviation may be evidence of associated scaphotrapezial arthritis. The symptoms typically wax and wane, and a period of non-operative management with splints and analgesia should always be the first line of treatment. The 3 classic orthopaedic operations are all options, but the first operation described was by Gervis at a meeting of the Royal Society of Medicine in 1947. He went on to have the operation that he had described. The surgical approach can be palmar, as seen in this slide of Harry Belcher's. The tendon of FCR is reflected, allowing the trapezium to be excised in one piece. Or you can use a dorsal-radial approach. The artery is mobilized, the capsule elevated, and the trapezium is split to allow piecemeal removal. Since its inception, there have been concerns regarding instability of the joint following simple trapeziectomy, and a variety of procedures have been described to mitigate this. Many use part of FCR, and some are really quite complex. So, with apologies to the bard, to sling or not to sling? That is the question. Well, there's little evidence in the published literature of any benefit to any form of sling or interposition. As part of a large body of work on the arthritic thumb, Professor Davis has produced the definitive study with a long-term follow-up of a randomized trial of 100 patients in which no advantage could be found to a ligament reconstruction and tendon interposition. Just over 80% success was reported in both groups. What do I do? I use a dorsal radial incision with an approach between the tendons of EPB and APL. I protect the subcutaneous branches of the radial nerve and the artery. I carefully elevate the joint capsule, split and excise the bone. I then take one of the slips of APL and pass it around FCR as a simple sling, avoiding undue tension. I repair the capsule, release the tourniquet, and then close the skin. It takes around 30 minutes skin to skin, unless the bone's very hard. The patient then has 3 weeks in a soft dressing with a strip of plaster for reinforcement, and then they move into removable splint. It usually takes around 3 months for the patients to recover. About 85% are happy, and the results seem to be durable. I don't use trapeziectomy in younger, high-demand patients. In conclusion, thumb base OA is very common. It's not always symptomatic, and you should try a period of non-operative management initially. For most cases, simple trapeziectomy is the gold standard, and there's no objective evidence for tendon slings. Thank you very much for your attention.